next one, Dr. Satyaswarup Tripathi. Dr. Satyaswarup Tripathi, please ask your questions. Your time for asking questions starts now. You have 10 minutes to ask both the teams.
Good evening. What is your diagnosis in this particular case?
So this is a case of a left side complete cleft, which is involved along with the nasal deformity, and along with the nasal deformity. So I would like to rule out this.
How do you differentiate between complete and incomplete cleft?
So in case of the complete cleft, the nasal sill will be absent. The cleft will be extending up to the floor of the mouth, whereas in case of an incomplete cleft, the nasal floor will be intact.
So how will you proceed in this particular case?
So um,
Your voice is not audible.
Your voice is not audible. Dr. Tripathi, for the first two questions, are you satisfied with the answer from the team?
Yes, yes.
Then we'll give full marks for the first two questions to. Okay, third question. Your voice is not clear. Please talk again.
Begin with counseling of the parents. The parents needs to be counseled about the nature of the disease. First, I need to assure them that.
Your voice is breaking.
Team TNMC, your voice is breaking according to sir. Could you repeat the answer?
So I would like to proceed by counseling the parents about the nature of the disease. I would like to counsel the parents about that the disease is curable. There are treatment options available for this condition. I would counsel the parents about the need for the various surgeries. I would counsel them about the need to rule out other congenital anomalies, other syndromic associations, and I would give them advice on the feeding of the patient. Then, as it is a cleft, I would like to go ahead with the pre-surgical infant or orthopedic management in this patient, and then eventually at 3 to 4 months of age, I would like to go ahead with the cleft lip surgery.
How will you investigate?
I would like to do the complete examination of the patient, in which I would do I will examine the patient for the cleft palate. I would examine the patient for the I would do basic investigations like sonography and 2D echo to rule out the other congenital anomalies associated with this patient, and I would like to do the basic routine investigations from anesthesia workup point of view.
What are the basic workups?
Are you satisfied with the answer, Dr. Tripathi?
Yes, yes.
Okay. Next question, sir.
What is the criteria for a good lip repair?
Would you like to pass the question?
According to the Millard's criteria, I would like to consider the operation of the patient, which is the age of the patient should be more than 10 weeks. Then the weight of the patient must be more than 10 pounds. And the hemoglobin must be.
My question is, what is the criteria for a good lip repair?
Would you like to pass the question, Dr. Tripathi, to the other team? Or
yes, other team can answer.
So the criteria for a good lip repair is that the scar should be at the filter column, and there should be a good vermilion to vermilion opposition, sir, with also the nasal deformity correction.
Are you satisfied, Dr. Tripathi?
I think it can be made better, but it's okay. How
do
you classify this? Yes.
Please,
how do you classify this one?
This question is for team A.
Team A, yes.
Yeah.
So according to the Nagpur classification, there will be group 1, which is cleft lip. group 1A, which is cleft lip plus alveolus. Then group 2 is cleft palate. Then in that we have group 2S, which is cleft of the submucous palate. And then we have group 3, which is cleft of the lip plus cleft of the palate. Then so another classification
In
is
the
it can either be a complete.
this case falls to which category? As per the Nagpur classification.
So this case
Your voice is not audible.
fall to category 1. 1A. All in category group 1A.
Okay, Dr. Tripathi, would you like to ask questions to the next team now? Because 5 minutes for team A is over. They have received
Yes,
6
yes.
questions. So you can
Yes.
go. And are you satisfied with the last answer?
Group 1A, she told. Actually,
Okay,
can't.
you can pass. You can pass on. If you are not satisfied, you can pass
Yeah.
the question to other team.
The team B, can you classify as per this Nagpur classification?
Sir, I'd like to see for the cleft palate. If it's there, then it is the group 3. Or in case the palate is not there, then it is group 1A, sir.
Okay. So how will you repair this case?
Question
Sir,
is now for the team 2, team B.
Yes.
Yes. Sir, I'll go with the triangular flap repair, sir. And for this child.
What is triangular lip repair?
Sir, in that the a triangular flap is created in the cleft side lateral lip, and that is advanced into the defect which is created in the non-cleft side. We make the points 1 to 9, and the triangular which is created in the non-cleft side, it is sutured from the cleft side, sir.
The triangle you will obtain from which side?
The non-cleft, the cleft side, sir. The cleft side, lateral side, sir.
Lateral lip element. So what is the difference between Millard repair and Tennyson repair? Can you tell the differences?
Sir, in the Millard's repair, we do that is a medial rotation and lateral advancement flap. So the medial lip element is basically rotated, and the lateral lip elements are advanced into the defect. In that, there is a back cut which is used to for adjustment of the underlining the defects, sir, for making the alignment, sir. And in the triangular flap, the markings which are used is according to the equilateral triangle, the plumb lines and the defect which is there. It is according to the same markings, sir. That is the X which is calculated according to the plumb lines. So that is used for the making of the equilateral triangle on the lateral lip elements in the this rental Tennyson, sir.
Which is more difficult to repair? Unilateral cleft lip, bilateral cleft lip?
Are you satisfied with the previous answer, Dr. Tripathi?
It's okay. It's okay.
Yeah, okay.
Sir, unilateral cleft lip is difficult, sir.
Why?
So because placing the scar over the filtral column and advancing the both the lip elements, it is that is basically a challenge in the unilateral cleft lip. And in bilateral, we have the medial premaxilla tissue. So that is the guide which is there, so that both the lip elements can be sutured to the premaxillary segments.
Answer could have been a little bit better. Anyway, what are
Would you
the
like to
post-operative
pass-
care? Yeah,
would you like to
can
pass the
team
question,
A?
sir?
Yeah, can team A answer this question?
So the unilateral cleft lip is difficult to repair because the aesthetic achievement is difficult, as we have to compete with the normal nature's creation. Whereas in case of bilateral cleft lip, we can, with the correct management of the premaxilla and with the correct pre-surgical management, we can achieve a good repair.
Correct. So,
Is it okay, Dr. Tripathi? Shall we give them
yes,
one mark?
yes. Yeah, can be given. Yes.
Okay. Next question.
What is
to
a
team
wide cleft? Team B.
The wide cleft is if the defect is more than 1/3 of the maxillary this processes, sir. So if it is more than 1/3, it's called wide defect. If it is less than 1/3 of it, it's called a narrow defect, sir.
So for the wide cleft, how will you manage it? Which method of repair you prefer?
Would you like to pass the question, Dr. Tripathi?
Yes.
Your time is also up.
The other team can answer.
So in case of white cleft, first we need to start with pre-surgical infant orthopedic management. We would like to go ahead with a nasoalveolar molding technique, and then after in the initial 2 weeks of the birth, after that we will go ahead with the Milliard's rotation advancement chiroplasty technique to correct the defect.
Are you sure? For the wide cleft, which is a better method of repair among the Tennyson and the Millard?
So
It's okay.
Okay. So, Dr. Tripathi,
It-
your time is up. 10 minutes
Yes.
are over. Now
Okay.
we'll go to second panelist, Dr. Sunil Raut. So please start questions with team A on the same spotter.
uh,
Dr. Sunil?
Milliard
Yeah. Okay. So
Yes.
rotation advancement flap because the triangle to cover the flip.
Dr. Sunil, please ask your questions to team A,
okay.
then team B,
So
either alternate or one by one after other.
so question for team A. So you were telling about the Nagpur classification of this clade. So would you not like to have the intraoral examination to before finally
So,
you are filling your classification, which type it falls into?
yes, sir. Before classifying it, I would like to do a complete intraoral examination to
But
rule
from this
out the
picture,
cleft
we
palate.
can't see the intraoral part. We can't see the palate. We can't see
No,
the
sir.
alveolus clearly from here. Okay. Although it's evident that it's most apparent that it's a complete type of cleft. I mean, Nagpur type 3 left side. So, but you should reply that like that. I would
Dr.
like
Sunil,
a
Dr.
detailed
Sunil, please
explanation
ask the questions. Please
Okay,
ask the
fine.
questions because your time will go up. Explain we
Okay,
can
okay.
do after the session is over.
And you were telling about the counseling of the family members, the parents. What else you will counsel for the other members of the family, like the in-laws of the lady who was given birth to this child? Anything?
So I would like. I would
Yeah.
like to counsel them that there is risk of the recurrence of this disease in the future child, in the future pregnancies, because one sibling is positive. So I would like to counsel them. Besides that, other factors I would like to screen the patient, which we can prevent in the next, like the nutritional status, because of the folic acid deficiency or because of the exposure of certain teratogenic drugs, which could have caused. I would like to screen for the etiology and counsel them to take the precautions in the subsequent pregnancy, and genetic counseling for recurrence in the future generation.
Fine. So, which is the drug which has been scientifically proved to have an etiological role in the development of cleft? Most important drug. Scientifically proven.
So phenytoin,
Yeah, good.
so
So,
sodium valproate phenytoin.
yeah. We were discussing about the surgical repair of this cleft child. So, Dr. Shani's technique is already a published technique, and it's a variation of the variant of the triangular flap technique or the rotation advancement technique. Dr. Shani's technique, you know?
So it's a variation of the.
Sorry.
So Dr. Sani's technique. So it is a variation, or it is a modification of the Randall Tennyson technique. He has given more precise geometrical landmarks to make a smaller triangular flap.
Yes, that's good. Okay. and we are discussing about the pre-surgical orthopedics and nasoalveolar molding. So, what exactly or mostly you intend to gain from the nasoalveolar molding of this child or unilateral cleft lip and
Uh,
palate?
so so in case of nasoalveolar molding, it will help to align the alveolar arches which would have been collapsed. It will help to align the dentition, and at the same time, it will help to mold the nasal. It will help us with the nasal asymmetry. It will help to reduce the nasal asymmetry by bringing the alar cartilages close by.
Okay, can you enumerate the pros and cons of early repair of cleft lip also? Cleft lip. Before you were discussing that rule of 10 described by Dr. Millard. So suppose we, some of the surgeons also do the surgical correction of cleft lip in the perinatal age, just after birth, or maybe as early as possible. So is there any advantage or disadvantage doing
So the
repair?
disadvantage would be the disadvantage would be the growth center which is there in the pre-maxilla. We can hamper the growth center, and also if the maxillary arches is not aligned prior to the surgery, if not adequate time is given, the repair will be difficult. There will be a tension on the repair, and there is more chance of recurrence and breakdown of the surgery.
And the quality of scar is better if it is operated early or operated
Are-
late.
Okay. Are you satisfied with the answers?
Yeah. That's okay.
Okay. Please answer this question. Are you quality of care is better early or late?
So the quality of scar
Quality
will
of the
be
lip scar, post-operative scar in the lip is better if it is operated early or if it is operated late.
so if it is operated late, because the collagen fibrils.
Would you like to pass the question, sir? Would you like to pass the question?
Yes, the team B.
Sir, the scar should be better if it is operated early, sir.
Any reason?
Sir, because the skin usually it will be more pliable, and as well as the time, the more the time, the scarring and the it will be better, sir. So collagen, even the collagen will be better in the early stages of the life, sir, in the newborn, sir. So early, if it is repaired, the scar will be better, sir. Then the type it is converted into type 3, so it is the collagen bundles will be matured, so it will not give a good scar later on.
Are you satisfied with this answer, Dr. Sunil?
Could have been better, but yeah, okay, we can give the marks to them. To the,
We'll give them full mark or 1 mark?
I think half.
Half, okay.
Yeah.
And now
I mean,
the
half of
questions
the
are
full
going
mark.
to team B. Now the
Half of the
questions are
full
going
mark.
to team B
Okay.
because 5 minutes are over for team A. Please ask your questions for team B.
So, team B, if I ask the same question in case of palate repair, because it looks like a case of complete cleft or Nagpur classification class 3, type 3 of left side. So, in case of palate repair, if we do, what is the best age or most appropriate age to go for the primary palate repair?
1
Three
12 months, 12 months,
3 months.
3 months to 6 months, sir. 3 to 4 months.
Team Nair?
Sir,
Primary palate repair. Most appropriate age of the child to undergo cleft palate repair, primary cleft palate repair.
sir, most appropriate age is 9 to 12 months, sir. Since the baby starts babbling at 6 months and the speech gets established by 1 year. So before establishment of speech, we should correct the palatal defect.
Yes, it's correct.
So we'll give 1 mark to team A.
Yes.
This is a
So
past question.
Coming back to team B again.
Sir.
When did you say that the cleft treatment is complete for a child to the family members? Suppose the child is having cleft lip, alveolus, palate, everything. So After which surgery you will say that your child's treatment is complete?
Sir, after the cleft palate and doing the veloplasty, the child is started on the speech therapy, and if it is effective, then we say that the surgery is complete, sir. Our motto is mainly the speech correction. So if it is achieved, then our surgeries are complete.
You don't expect anything, any change after the child is grown, after the following the cleft lip repair, cleft palate repair?
Sir, the nasal regurgitation of the liquid.
Other than the speech, I mean, other than the speech, supposing the child is speaking well.
Sir, the regurgitation of the food and from the nasal cavity, it is also, and mid-facial growth, both are taken care of. Then we say that it is complete, sir.
Or else indirectly you can you elaborate the stages of the treatment of a complete cleft lip and palate child?
Are you satisfied with the previous answer, sir, Dr. Sunil?
Yeah, it's not.
If you're not satisfied, you can pass to the other team.
Okay, you Team Nair.
Team Nair, answer the previous question.
Sir, in this particular case, the baby might require a minimum of 4 to 5 surgeries, depending on associated cleft lip. According to the Philadelphia protocol, first we would like to go for cleft lip repair at 3 to 6 months of age, followed cleft lip with anterior palate repair, followed by cleft palate repair at 9 to 12 months of age. Then this child might require primary rhinoplasty at 5 to 7 years of age. Also, he might require alveolar bone grafting for bridging the gap between the alveolus, and at 5 to 7 years of age. And if the patient has velocardiofacial insufficiency, the patient might require secondary procedure at 11 to 12 years of age. And at the development of costal cartilage at 16 months years of age, the patient might require secondary rhinoplasty, sir.
Okay.
So next question for Team B, sir. You have to ask, I think, 3 more questions to Team B to match the number of questions.
Okay, for Team B, we were discussing about ruling out the other anomalies, congenital anomalies in a case of cleft lip or cleft lip and palate. So, what is the most common cardiac anomaly associated with cleft lip and palate? Most common cardiac anomaly associated with cleft lip and palate.
If you don't remember, pass the question, Team B, because time is going up. You will lose your.
Sir, atrial septal defect, sir.
Yes.
So 1 mark to Team A. Okay, next question, sir. 2 more questions left.
What is the sorry, we were discussing about the, we have already discussed about the etiological factors. So, any, can you name any syndrome which is associated with cleft palate, Team FMC? Common, very common syndrome associated with cleft palate.
Sir, Vanderwood syndrome and also Down syndrome and Treacher-Collins syndrome. Sir. These are the commonest ones which are associated with the cleft lip and palate.
Okay. The most common, it's also called sequence, may not be.
Sir, Pierre-Robin sequence.
Yeah. I was expecting that as the first answer. Okay. So what are the other anomalies associated with cleft palate in a case of Pierre-Robin sequence?
Micrognathia is there, sir, and there is a relative glossoptosis, as well as there is respiratory distress due to the obstruction of the airway, sir. So that is the mainly pathology in the Pierre-Robin sequence.
Are you satisfied, Dr. Sunil?
Yeah, yes.
Okay, so we'll get 2 marks. So that ends the questions by the panelists. Now I'll request our judges to please ask the question, sir. So Dr. Sunil, sir, please ask the question. You have 5 minutes to ask to both the teams, sir.
Okay. I'll ask to team A how
Yes,
the
sir.
lip is formed during the embryo and at what age the discrepancy is there. In this case, in this spotlight.
So this would have occurred around 6 to 7 weeks of age because of the failure of the fusion of the median nasal process with the maxillary process on the left side. So normal development occurs around 4 to 10 between 4 to 10 weeks of the intrauterine life, and at first week the frontonasal process develops, then the maxillary and the mandibular process develops. By the end of fifth week of gestation, the median nasal process is well developed. Around 7 weeks there occurs the fusion of the median nasal process with the maxillary process. Because of the interruption in the fusion around this age, there would have been a cleft. There would have been a cleft lip in this patient.
There is one lateral nasal process also.
Sir, can you?
Can you repeat
Sir,
the
I'm
question?
sorry.
There is lateral nasal process also.
Lateral nasal.
Yeah. So lateral nasal process is not involved in this patient.
Okay.
Are you
So you
satisfied with the answers, both answers, sir?
yes, sir.
Sunil, sir?
Yes, sir.
Yes, sir. Yes, sir. Please question. Next question.
Now to team B.
Sir,
Team B, sir.
Regarding the in this patient which is presented 3 weeks old, and what are the advice you give and what are the examinations you do? What are the anatomical evaluation that you do for this patient?
Sir, I'll counsel the parents regarding the syndrome associated, as well as the I'll assure them regarding the cleft palate and lip defect. Also counsel them around for their relatives if and the future siblings they are planning, and the whole age wise what is the surgery which has been planned for the child. I'll explain to the parents about the feeding regimens which are to be followed, and the how to feed the child properly using the palate or the spoon feeding which is there, and um,
A child of 3 weeks age. A
yes,
child of 3 weeks age. How much amount and how much duration can you advise?
Sir, are you
uh,
satisfied with the
for
previous question, sir? Are your previous
Pardon?
answer, sir? Are you satisfied, Sunil, sir?
No, it's
The
not
previous
complete.
answer?
It's not complete.
Would you like to pass
Previous-
it to the other team?
Sir, regarding the feeding, you are asking how many feeds which are required, sir?
That is what I am asking.
3 weeks old.
Would you like to pass the answer?
Sir,
You're
I'll
losing the time.
ask the mother to feed the child using a palate spoon and burp the child every time she feeds. Always keep the child upright at around 45 to 60-degree angle, so that the child doesn't regurgitate any the liquids taken or the feeds which is taken. Breastfeeding will be difficult for this child, so we recommend spoon feeding, the expressed milk and the palate feeding, sir.
That is all right, but what about the amount and what about the duration?
Sir,
The 1 hour
question can go to
half an hour.
go to team A. Sunil, sir,
Do you
question
understand?
can be given to team A.
Yes.
Team A, please answer the question.
So we can feed the patient in every 2 hours. So there is no specific time. The patient has to be given small feeds, and the number of feeds has to be increased. So we can space the feeds in every 2 hours and feed the child.
What are the further difficulties the patient will be having besides feeding in the early childhood?
Um,
Besides feeding and local deformity, what are the problems the child will be facing in the early childhood?
Sir, this is so
Situation-
team B or team A, sir?
Team A,
Team
team
A,
A.
team.
Team A. So the patient will have recurrent ear infections. The patient will have recurrent nasal, recurrent upper respiratory tract infections, recurrent and difficulty in swallowing, and there will be difficulty in.
Okay.
Are you okay with the answer, sir?
Yes, yes. Yes.
Okay, team A, 2 marks. Next question
What
for
are the
team B, sir.
advantages and disadvantages of mirror repair? Team A.
This will
So
go to
the
team B, sir. This
Team B.
question will
Team
go
B,
to
sorry.
team B.
Team B.
So the advantages of Palate repair is it is a relatively simpler technique, and the scar is a triangular scar is present over the filtral column. Disadvantages is that the advancement of the triangular flap is limited to the midline, so we cannot advance the flap. Um,
You have to name five advantage, five disadvantage.
Sir, would you like to give the question to team A now? Are you sir? Shall we pass
Yes.
the question to team A, sir?
Yes.
So
Team
the
A answer.
advantages of the Millard repair is the suture line will lie along the filtral ridge, mimicking the natural filtral column. Also, by extending through the same approach, or we can do an primary open approach in the through this in the same sitting. Whereas in the case of the triangular flap, the scar will be present around the midline, and it is difficult to revise the scar in the case of the triangular flap, as opposed in the Milan, where we can revise this scar in the future stage if needed. Also, the approach to the nasal deformity is difficult, and it needs a separate incision in case of triangular flap technique.
Sunil sir, are you satisfied with the answer?
Yes.
Okay, sir, we'll give half mark to team because this was a past question. And sir, Sunil sir, your time is up. 5 minutes are over. Now we'll request Farooq Bhatt sir to please ask questions for 5 minutes to team A and team B.
Okay. So the first question to team A, can you just name for me muscles of palate? Team A.
Sir, muscles of palate are levator villi palatine, tensor villi palatine, palatoglossus, and palatopharyngeus.
Anything
And
else?
macula uvulae.
Very good. Question to team B. Tell me blood supply of palate.
Sir, it is mainly by the greater palatine artery than the part of the lesser palatine artery, sir.
Anything else? Can we pass to team A? You want to add something?
So by the nasopalatine branch of the maxillary artery, and then by the greater palatine artery and the lesser palatine artery.
Okay, 1 mark for you.
1 mark.
Next question for team A, right?
A sir. Yes,
Yeah. Can you classify vessel deformity?
So it is divided into 4 classes, but I'm not sure of the classes. Sorry.
You're not sure. Pass to team B.
Pass, sir.
both
Pass to team B.
they also could not answer.
They could not answer. Okay, next question. How will you manage
B.
the scar of a operated cleft lip?
Team B.
Sir, we recommend scar massaging with bland oil massage, and in the post-operative period, we remove the sutures early, and we use lipped steroid strips for quite few weeks post-operatively, so that the scar doesn't have any tension, and
Anything else?
and
Okay. Okay, this was a past question, right?
This was a direct question for Team B. If
This was the-
you
okay.
want, would you like to pass to Team A, sir?
Yeah. Can we pass to team A? You want to add something?
So along with that, lip taping with silicone sheaths, and if the
Yes.
scar is still hypertrophic, then triamcinolone injections can be given.
Good. Very good. Something? Anything else?
So fat grafting
Microfat.
in the fetus.
Okay, I think it's accepted. Okay. Now the question to Team A.
Yes, sir.
How will you evaluate VPI, vilopharyngeal incompetence?
So for evaluation, we would like to do a nasal endoscopy to look for lateral wall movements of the pharynx, sir.
Anything else? Is that enough?
And video fluoroscopy to rule out regurgitation.
Very good. Anything else?
And we would like to document the nasality of the speech pre and post procedure.
Very good. I think it's accepted. Okay, fine. Next question to Team B.
B.
How will you decide about the surgical procedure in case of a VPI? Which procedure you will do? Okay, let's put the question first. What are the various techniques of doing correction of a VPI?
Sir, if there is a anterior posterior ligament which is short, then we do a double opposing Z-plasty, so that the length of the soft palate is achieved, so that it covers the pharynx, velopharynx, this distance, and then if we have transverse.
Pass Team A.
Sir, depending upon the movement of the lateral walls of the pharynx, if there is lateral wall movement, then we will like to augment the anterior posterior length of the palate by doing a Furlow's double opposing Z-plasty. There have been previously morbid procedures described like superiorly based pharyngeal flaps, which acts as an obturator, and augmentation of the posterior pharyngeal wall to decrease the distance between the soft palate and the posterior pharyngeal wall.
How will you augment this posterior pharyngeal wall?
Is it a direct question or?
Is there a direct question? Direct question.
Direct question to Team A. How will you augment the postopharyngeal wall?
So by doing a pharyngeal flap procedure to augment the passivant ridge.
Any other technique you know? Team B.
Team B.
Pass, sir.
So one more direct question left for Team
Okay.
B.
Team B. Okay. Can you describe me all the features of this child in nose tip? What are the various abnormalities?
Sir, starting from the columella is shorter on the cleft side. The tip of the nose is deviated towards the non-cleft side. There is LLC flattening on the cleft side with the base which is moved downwards and outwards and posteriorly. And the nasal floor is also discontinuous. There is a cleft in the nasal floor as well. And the septum would be deviated towards the non-cleft side, sir.
I think it's okay. Do we have time, Doctor?
Your time is up, sir.
Okay,
sir.
fine. Thank you.
So thank you very much. Now we'll go to spotter number 2. This is spotter number 2. It will start with panelist 2, Dr. Sunil Raut. Please ask questions to Team B, then Team A for 10 minutes. Dr. Sunil Raut.
Yeah, I'll be asking to which team?
Team B, followed by Team A, or alternatively for 10 minutes.
Okay. So Team B, can you describe this clinical condition?
Sir, this is a 63 years old male and presenting with the sacral bed sore or pressure ulcer, which has infiltrated the skin and the dermis as well as embedded into the subcutaneous tissue. This will be most likely grade 2 since it is invading the subcutaneous plane. And upon
just wait. Why do you call it a pressure ulcer or pressure sore?
because it is.
Sir, are you satisfied with the previous answer, sir?
That's only just to ask for the diagnosis. It's okay, but the staging, I'll come to the staging again.
Okay, sir. No, should we give any mark for the previous question? What you asked?
No, there should not be any mark for the first question.
Okay. Then you can ask the first question.
Marking should start from now.
Okay, sir.
Why it is called? Let's start again. Why it is called a pressure ulcer or pressure sore?
Sir, because it is in the dependent pressure point area, which is the sacrum, and looking at the history, his history of stroke and paraplegia, and in the he's admitted in the neurology ICU. So, upon looking at the history, this could be a pressure ulcer, since there is no surrounding lesions or erythema or any kind of pathology which is seen in the surrounding region. This could be a pressure ulcer.
So, team A, can you try to have a better answer for this? Why it is called a pressure ulcer or pressure sore?
So it is it is mainly because of the ischemia of the skin and the underlying tissue over a bony prominence because of the lack of because of the obstruction of the capillary perfusion which is occurring in a case of a patient who is having paraplegia and is immobile.
Okay, I think they have a better answer.
So both will get half of marks?
Yes, I suggest that.
Okay, sir. Next question, sir.
So now coming back, which stage, team B, you were telling about the staging, which stage you think this ulcer is of?
This is stage 2, sir.
Team A?
So it is a stage 3 ulcer as there is a presence of slough in it and there is full thickness breach of the skin.
Yeah, I think they are more appropriate.
Team B, Team A will get half mark, pass mark because of this, and Team FMC will not get anything. Next question, sir.
Coming back to Team B again. Team B, what is the duration of pressure? If not relieved, it gives rise to the development of pressure sore.
So 2 hours is the duration. If it is not relieved every 2 hourly, then for at least 5 minutes, then it causes a pressure ulcer.
Yes, that's correct. Usually there is a range, but even 2 hours also is the minimum time which has been seen that that can give rise to this type of pressure sore or pressure ulcer.
So we can give full marks to Team B.
Yeah. So how frequently we should change the posture of that patient?
Sir, for every 2 hourly for 10 minutes is the recommended guideline for changing the posture.
Okay, fine, correct.
Okay, all right.
There is a scale which is used for to predict the development of pressure sore.
Sir,
can you name it?
Sir, this is the Braden scale which we mostly use to know the predictive risk for developing a pressure sore.
Okay, good. So the higher score is better for the patient. I mean, less risk or higher risk? Higher the score, higher the risk or lesser the risk?
Lower the score is more risk, sir.
Okay.
Sir, lower the score, more is the risk, sir.
Yes, correct. So, how do we proceed for managing this case?
Sir, we evaluate the patient his blood parameters, the hemoglobin values, and as well as the albumin levels to check the nutritional status. And we try to correct the hemoglobin as well as the albumin levels. Then secondly, we look for the moist, like is the dressings getting wet and the patient has incontinence or not. We need to keep that area dry and clean, and as well as use air mattresses or alpha mattresses to relieve the pressure from the sacral region. And recommended position change at 2 hourly intervals for 10 minutes. Then we also look for the shear, which is if it is present, we try to position the patient supine, and if it is there, the recommended that it is 45 degrees recommended for the patient. Then we try to keep the patient supine so that the shear and friction can be reduced. And dressings can be done, sir. For this, we use initially wet to dry dressing so that the slough and everything can be removed, and then later on we can plan for the surgical management.
Sir, 5 minutes are up for team B. Now you can ask the question for team A, sir.
Okay, coming to team A, we are discussing about the Braden scale. What figure the scale? What is the scale? What is the figure which indicates the highest risk? What is the score? What is the score which indicates the highest risk? Do you remember?
So score 6. Score 6 is the score which indicates the highest risk.
Team B?
Yes, sir. Score 6 is the highest risk, sir.
It's 6 or 9?
Sir, 6.
Okay.
6.
So any marks for team A, team B, sir?
Then team A,
Anil, sir?
team A should get the credit. They have
Okay,
answered
all right.
first. Okay. So, so supposing for this, when you decide to go for a definitive surgical procedure in a pressure stroke patient?
So a definitive surgery should be planned only after the pre-operative optimization of the patient. We need to address the nutritional status of the patient, the hemoglobin levels of the patient. We need to see the compliance of the patient with a frequent change in positioning. And if possible, we need to address spasticity as well in such patients. And we need to see the compliance of the caregiver and the patient.
Okay. Okay, that's correct.
Okay.
So, what assessment is most important to before going or proceeding for a flap reconstructive surgery in a case of pressure stroke?
So osteomyelitis has to be ruled out before
That
going
can be
for the definite.
that you can debride, that you can manage during debridement. So, any patient-related condition?
So incontinence.
No, not exactly. Supposing the patient is not able to be ambulatory, or the patient cannot move himself or herself, would you like to go for a flap reconstruction surgery, because it's very easily said rather than
Would you
done
like to pass the question, sir?
for it to yeah. Okay, I have already given the hints, so maybe it's
So
okay.
Then
You
we
already
can
answered
go
it.
to the next
Maybe they
question, sir.
can maybe they can give the marks. Okay.
Yes, sir. Okay.
So basically, unless the patient is ambulatory or
Hello.
patient is not able to change the position himself or herself, it's
Okay, sir. Okay, sir. Sure,
it's
sir.
not ideal to
Thank
go
you,
for a
thank you,
flap
sir.
reconstruction surgery, because it may fail again. The flap may necrose within a short period of time. Okay. So any newer modality of dressing you would like for this type of ulcers?
So dermal matrix are the newer modalities which can be used to address the patient. But before that, and there has to be adequate debridement of the wound, and the slough has to be debrided. The dead space have to be obliterated, and the osteomyelitis have to be dealt before applying the dermal substitute, skin substitute.
Okay. Anything Team B can add? Any modality, newer modality of dressing to help in this preparing these ulcers for surgical management?
Sir, NPWT, this can be used.
Yes, very good. So maybe the marks can be divided between both
Okay,
the
sir.
groups.
Yes, sir. Next question, sir.
So Not exactly for this case. Maybe if the pressure sore is on trochanteric area or the ischial area, then would you like to go for a muscle flap for better recovery if you are going for the flap reconstruction surgery?
So for trochanter and ischial, faciocutaneous flaps are often considered to be better.
So tensor facial lata is the flap of choice for trochanteric pressure sore.
Yeah, full marks to the team because not faciocutaneous flaps are not usually the flaps of choice for deeper ulcers. So your partner answered correctly. So if you have an option to use musculocutaneous flap or the muscle alone, that's musculocutaneous flap in fact is the best choice. So tensor facial
Full
lata
marks,
is
sir.
better choice for trochanteric ulcer. Correct.
Okay, sir. Next question, sir. We
Okay.
have to ask two more questions, sir, to match both the teams.
Okay. And what is the first surgery you would go for the pressure ulcer? Supposing the ulcer is having a layer of eschar over it and it's very difficult to classify at the outset which stage of the ulcer is it? What is the first step of surgical management you would go for?
So surgical debridement of the pressure ulcer has to be done
Yes,
to look the actually stage the disease, and
yes.
if needed, we should also do birsectomy for surgical debridement.
For an ischial pressure sore, deep ischial pressure sore, having a bursa, after debridement and everything, good debridement, which muscle or myocutaneous flap you would prefer? Ischial pressure sore.
So if we have to go for a musculocutaneous flap, we can do a gluteus maximus advancement flap. Otherwise, the flap of choice is tensor fascial lata flap. If needed, we can use vastus lateralis muscle
Ischial
alone.
it's not for the ischial, it's for the trochanteric.
Gracilis muscle.
So gracilis, for ischial gracilis muscle.
Yeah, gracilis is the better choice. Yes.
Okay, sir.
I
So
think we're
that
done.
ends, that matches both the team questions as well as your time is up, sir. Sunil sir. So now we'll ask Dr. Satyaswar Tripathi to ask his questions. Starting with team B.
Team B.
Dr. Tripathi.
Yeah. Thank you. So, how will you debride this particular ulcer? Team B.
Sir, we'll excise make the edges raw, and since it is a chronic ulcer, we'll try to convert it into an acute ulcer. We'll debride all the edges, the margins, as well as the pseudo bursa inside. And in case there is a osteomyelitic component, we'll try to debride the necrosed bone as well as remove the a bone which is involved. And yes, sir, that is the first stage of debridement, sir.
How do you ensure that you have removed everything?
Sir, we use methylene blue stain to highlight the ulcer area, and during that debridement, we try to include all the marked areas, sir, all the walls of the ulcer.
Will you little bit better answer? You pack the wound with methylene blue soaked gauze, and you
Yes,
don't see any methylene blue around.
Yes,
That
sir.
is the pseudotumor approach.
Yes, sir. Yes, sir.
So why it is particularly important?
So we'll give full marks to the first question, sir.
Yeah.
Dr. Tripathi.
Can.
Yeah. Okay. Second question again.
Why it is important?
Sir,
What is there in the wound bed which you want to address?
the pseudo bursa, sir, because it will the bursa will recur and it will cause incomplete debridement of the ulcer, and it will interfere with the mainly the healing process of the if it is stage 2 is planned for the surgical closure of the wound, then it will cause exudation and give away of the sutures later. That's why it is important to clear the pseudo bursa, sir.
What is a biofilm?
Sir, biofilm, it is a layer of the bacteria colonized as well as the neutrophils, which doesn't allow the local antibiotics as well as systemic antibiotics to penetrate the wound cell.
What is that particular thing which prevents the antibiotic for penetration inside a biofilm?
Is this a extra question or part of the same question, sir?
Part of the same question.
Okay, all right. So then you need to answer both. FMC team, please answer.
Team A. Team A.
Okay, team A, please answer.
So it is because of the extracellular polysaccharide complex that the penetration of the antibiotics is prevented in case of biofilm.
So what are the methods to overcome?
This question
So
is
we need
for
to first
team B or
clean it with methylene blue.
this question has been presented directly to team A. Dr. Tripathi?
Yes.
What are the method? Yeah. Okay, team A, direct question for you. Please answer this.
So we need to first stain it with the methylene blue, and
They
then
already told. What are the other methods?
So we can use chemical agents like Dakin solution, or we can use acetic acid. Dilute acetic acid solutions can be used.
Okay.
They get full marks.
What is that called? What is yes, can be given. What is CT for microbes?
Sorry, sir.
CT for microbes.
CT for microbes.
Okay. Fine. Question to team B.
So the last answer, they got it correct? Dr. Tripathi?
Yeah, it's correct.
So team A gets it right. Okay.
Team B.
No.
Team B.
Yeah.
So what is the thing used in NPWT?
Sir, we use a foam which is placed over the wound basically, and cover it with the waterproof sheet which is there, so that it creates a vacuum, and that is mainly used for the NPWT, sir.
So what is the difference between that foam and the ordinary foam which are available in the market?
The size of the pore this ranges from the 400 to 600 micrometers, sir. That is the main difference, sir.
Yes.
So full marks to team B?
Yeah, full marks.
Okay.
What are the other newer modalities of treatment for achieving wound healing in bed sore?
Question for team B or team A, sir?
Team B.
Okay, team B, answer this.
Sir, use of we can use sir, placentrix and amniotic gels which are available, so that the granulation can be improved faster, as well as we can use a platelet-rich fibrins, so that the granulation can be achieved faster, sir. And that's it.
If you want to, yes. You want to treat, say patient is yes, okay. Team B, team A.
Okay, sir. The last answer, team B gets full marks?
Yes.
Dr. Tripathi?
Yes,
yeah,
yes.
Okay. Now we have to ask 3 questions to team A to match the number of questions. Can you ask the question to team A?
Team A. Okay.
Team A.
So the patient is paraplegic. So what precaution you want to take if you want to plan a flap for this type of patient?
So the paraplegic patients will have increased spasticity. The spasticity has to be addressed. I need to look for the incontinence in these patients, which has to be addressed. Another experiencing factors like moisture and bed positioning.
Those things you have already told. These are repetitions. I just want to know, if you want to plan a flap cover, what particular thing you need to address?
Rotation. Sir, we need to plan such a flap so that the extension of which can be used for in case of any recurrence which is expected in such patients. So we would like to go for a rotation advancement flap which can be used as an extension if recurrence occurs.
Yeah, you can plan a bigger flap. That's fine. That's a good answer.
Yes.
If there's a recurrence, you can plan a flap within a flap.
Okay,
That's
they get
fine.
full marks?
Yeah, it can be given full marks.
Okay,
So,
sir.
can you name a few flaps? And how the flap is
Sir,
better
for
than a
this,
flap? Yes. Yeah.
sir,
Please
for
name a few.
this, sir,
Yes,
for
yes.
this patient,
Your voice is
since it is
breaking.
a sacral ulcer, we would like
Yes.
based gluteal maximus musculocutaneous flap.
Yes.
Hello.
Yes, yes. Please go ahead.
Sir, also we can go ahead with superior gluteal artery perforator flaps in a VY advancement fashion, sir.
Yes.
Sir, and posterior thigh flap can also be used. And
Yes.
Lumbosacral flaps, the flaps based on the lumbosacral perforators can also be used.
Okay. So, what are the potential complications?
Are you satisfied, sir? Dr.
Yes,
Tripathi, with
yes.
the last
Okay.
answer?
Yes, okay.
Okay.
Yes, okay. What are
Okay,
the
sir.
potential complications? You won't treat. You don't do anything, but the complication the patient going to have.
Sir, if the ulcer is left as it is, it might progress. The grade of the ulcer might progress, and it might lead to osteomyelitis of the underlying bone in the later stage, which might eventually lead to septicemia and can be limb and life threatening also, sir, if nothing is done. Sir.
How will you prevent this?
Sir, we would like to. I would like to go ahead with a stable flap cover after ensuring adequate debridement and ruling out osteomyelitis.
Are you satisfied with the answer, sir?
Yes, yes, yes.
Your time is also up, sir. Thank you for your questions.
Okay.
Okay, sir. So we have equal number of questions to both team. Now we'll request the judges. Judge 2, that is Farooq Bhatt, sir.
Yes,
You have
sir.
5 minutes to ask both the teams, sir.
Question for team A. What is the flap of choice for covering an ischial bed sore?
Posterior thigh advancement flap. Posterior thigh flap is a flap of choice for racial bed. So,
Second question to team B. What is the arterial supply of posterior thigh flap? Team B. Can we pass? Pass to team A again.
so it is by the branches of the perforated branches of the profunda femoral artery, and also by the medial and by the collaterals by the lateral circumflex femoral artery and the superior gluteal and the inferior gluteal artery.
Okay. It's okay. Next question for team
A.
B. Team A or team
A,
B?
sir. Team A, sir. A, sir.
What do you understand by the term flat flap? F-I-L-L-E-T. Flat
Sorry,
flap.
sir?
Flat flap.
So a fillet flap is a kind of an advancement flap which is used to cover a defect.
Sir, it is detached from all its ends.
Your voice is
And it
breaking.
is, sir, it is a flap in which all the sides of the flap are. Hello?
Yes, yes.
Tell.
Sir, a fillet flap is such that all the flaps of all the sides of the flaps are disconnected, and the flap survives on the blood supply from the underlying subcutaneous tissue, sir, and the subdermal plexus. And it is advanced into the defects.
Not really. Pass on to team B.
Team B.
Sir, the fillet flap in which we use the subcutaneous plane as well as the muscular component to basically supply the cover the defect. which is based upon the subcutaneous plane of vessels, which is supplying the flap, sir.
Okay, next question to team A.
The next
What are the
question will go to
various
team.
dressings used
1 minute, sir.
for
It will go to team B, sir. Direct question
team B?
to
Okay,
team B.
okay. What is the role of hyperbaric oxygen in bed sores treatment?
Sir, HBOT will help in mainly granulation, provide the granulation for the tissue faster, and will increase in the epithelialization and healing process, and will make the wound from the wound size smaller, so that later on flap can be planned, sir, or any other surgical intervention can be planned, sir.
Okay, that's fine. Question to team A.
A.
What is your goal of a flap in a sacral bed sore like this patient? What are your goals in performing a flap surgery for a sacral bed sore?
Sir, the flap should provide a stable cover to the ulcer. It should prevent breakdown, and it should be in excess such that in a case of recurrence, it can be advanced, and the need for secondary flap is reduced.
It should not violate the territory of a second potential.
Again?
So it should not violate the territory of a second potential flap.
Okay. What is the most team B? I think
team B.
Team B.
Now question to team B.
What is the most important thing in counseling this patient? Pre-op.
Sir, in cases of patient like paraplegia, sir, we counsel them that this problem can recur if there is issue regarding the postural change as well as the nutritional status of the patient. And in case the dressings or the area is kept moist and there is frequent shear and friction on the same area, the problem can recur. So we have to counsel the relatives and the caretakers regarding all these issues, which have primarily caused the pressure ulcer. So if these things are taken care of, the ulcer will not recur again, sir.
Good. Question to team A. Team A.
Yes.
How will you position the patient pre, intra, and post-op, a sacral bed sore patient? What advice you give to the patient pre-op and post-op?
So the patient, intraoperatively, the patient has, so we have to give the patient prone position or the lateral decubitus position. We need to counsel the patient preoperatively about the position which has to be maintained, and the need to maintain this position. And before surgery, we can start giving this position to the patient to look for the compliance and make the patient comfortable with this position.
I will extend this question if the Dr. Devi allows me. How many weeks before you will start positioning the patient in prone position?
So the question is for us?
Yes.
So we need to place a foam mattress. We need to place a gel base or
how many days before the surgery you will start positioning the patient?
We need to provide a bolster support under the chest.
4 weeks.
Yes.
4 weeks, sir. 4 weeks before the surgery.
Can you pass to team B?
Sir, 2 weeks.
I think that's the correct answer. Okay, so you got half mark.
Pass mark. Okay, sir. Parag,
Do
your
done?
time is also up. Here you are done. Thank you,
Okay,
sir.
no problem. Thank
now
you.
I'll request Sunil Srivastava sir to ask 5 minutes question to both the teams. Starting with team B, sir. Sunil Srivastava sir, please ask your question to team B, followed by team A.
What are the various sites of pressure sore?
Sir, the sacrum, the ischial tuberosity, the greater trochanter, occiput, the heel area, then the shoulder blades, and in the if the patient is in prone position, then the knees can also be a pressure point, sir.
What are those pressure points?
They get
In prone,
full marks, sir.
prone position.
This
In
question they will get
suppose the
full marks,
patient
sir.
is in prone.
Sir.
Hello, same.
Sunil sir, this previous question they will get full marks. Team B.
Yes.
Yes. Okay, sir. Next question.
Now the post-operative care in this. Suppose you have operated this case.
Sir.
What are the post-operative care you provide to the patient?
Sir, we check for the positioning which is been recommended for this patient in case of sacral sore. Then prone position or a lateral position is recommended. So we'll check the position is appropriately maintained, as well as check that 2 hourly for 10 minutes this position is changed, so that we do not get any other pressure ulcer anywhere else, as well as the nutritional status of the patient, keeping the hemoglobin levels more than 10, as well as the albumin more than 3.5, keeping the dressings dry and clean, and taking care of the continence, which will not affect the dressings, which will not soil the dressings, and so that's it, sir.
Okay. What are the causative factors of getting a bed sore?
Sir,
One is
factors.
pressure.
Sir.
Yes.
Sir, positive factors, they will include the prolonged position, sir, especially
One is a prolonged position. What are others?
Others, sir, sharing forces in case the patient is positioned and the bed sheets are pulled in or out. When the skin is wet, moist, they are more prone for peeling of skin, leading to pressure sores. Then
as well as the infection due to the continence, fecal continence, incontinence, or the urinary incontinence. The patient usually, these kind of patients are in diapers. So the area is kept usually moist in these patients, which causes the breakdown, and as well as the infection to seep into the area, sir, which causes the break into the epithelium and causes the ulcers.
Okay, good. Now to team A.
Team A.
Yes. Correct. Now to team A. How do you manage this case? Operative management. First of choice. Your plan, first of choice.
Yes, sir. Sir, first you would like to evaluate the patient preoperatively for causative factors.
It is on the table. It is on the table. Everything has been done. It is on the table. Your first choice is what?
Sir, my first surgery would be adequate debridement and assessment of the depth of the ulcer to stage the disease, and find if it is deep, and I would like to go for one setting of NPWT, followed by the flap of choice for this patient will be an inferiorly based gluteal advancement flap, sir.
Okay. If that fails, then?
If it fails.
If that fails, then?
Sir, if it fails, then we will. I would like to do a lumbosacral artery perforator based flap, sir, or we can also do a VY advancement flap based on the superior gluteal artery perforator, sir.
From the same side?
Opposite side, sir.
Okay. If that also fails, then?
Sorry, sir.
Can I do free flap in this?
So free flap can be considered as an option, but in such a morbid patient where the chances of recurrence is high, we normally prefer a local flap over a free flap, but it can be considered.
Any random pattern flap?
Team A answer.
Sorry.
So the voice is breaking.
Sir, can you please
answer?
Sir.
Yes, sir.
Limburg flap can be planned, which is a random pattern flap, sir. In cases of smaller defects,
Rotational flap, sir, because the patient is 63 years old with stroke paraplegia, has a high chances of recurrence. So in case our flap fails, we can do another rotational flap in the later stage, sir.
Thank you.
Okay, sir. Thank